yes, sir.
We are live now. Please start.
Good evening, all. This is Chandra Mohan, physiotherapist from Sri Samraj Physiotherapy Center, Dindivanam, Tamil Nadu. A warm welcome to all for ExRx India's For the Students, By the Students web series. And today's first topic and ExRx India's 154th topic is SHIN Splints, will be presented by Michelle Lobo, third year BPT student from St. John's Medical College, Bengaluru. I welcome ExRx India team member, Dr. Rupesh and Professor Duna. Now I welcome our resource person, Ms. Michelle Lobo, to present her topic. Please, Michelle.
Thank you, sir. Yeah, thank you. Yeah. Good evening, all. I'm Michelle Lobo, third year physiotherapy student of St. John's Medical College, Bangalore. So I've chosen SHIN splints as my topic for today. So what is SHIN splints? Most of you would have experienced a kind of pain or discomfort on your shin bone. That is the bone which you can actually feel it on the anterior aspect of your lower leg. So this pain you would have experienced after your daily morning run or daily morning jog, or even after sprinting to catch a bus. So this pain would be very minimal, which would even disappear in 1 or 2 days. But in athletes or people who run kilometers on a regular basis, so they are more prone to get shin splints. The pain in them is so severe that it even lasts for a month or two. So today I'm going to talk about how physiotherapy can help such a population to prevent the shin splints and how we can treat shin splints. So I'm going to the next. Yeah. So I'm going to the next slide.
Rupesh, are you operating the slide?
No, sir.
You
can click on the slide.
Click on the slide, okay?
Okay.
Your pointer is on actually. Press escape button. Are you doing from laptop or phone?
Laptop.
Okay, now click on the slide.
Yes. I can go back to the pointer. Can I go back to the pointer?
Yes, of course. From bottom left, you can get that option.
Okay. So today's agenda will be, I'm going to talk about what is shin splints and what is the other name for shin splints. Then secondly, the muscle attachments. Third one, the factors which causes shin splints. Fourth one, what are the features we see in shin splints? Then fifth one, how we can investigate. Then the management of shin splints, and the most important thing, how we can prevent shin splints. Yeah. So the term shin splints or medial tibial stress syndrome, that is MTSS, describes a variety of conditions characterized by pain and irritation or inflammation, that is medial tibial periostitis in the lower leg. So the term shin, okay, the shin comes from the shin bone, which is the tibia. So historically, it was called as shin splints, but now it's called as medical term is given to it, which is known as medial tibial stress syndrome, that is MTSS. So shin splints is basically an exercise-induced pain in the tibia because of the inflammation of the periosteum of the tibia. That's why the name medial tibial periostitis. So this area, which you can see, will be affected. The pain will be here, distributed in this region between the mid of the tibia and the distal tibia. And the pain is more on the posterior medial part of the tibia. I'm going to the next slide. So these are the muscle attachments to the tibia or the lower leg. First is the triceps surae, which consists of gastrocnemius muscle and underneath gastrocnemius, we have soleus muscle. So these two muscles help in ankle plantar flexion. Then these are the superficial posterior muscles. These are the deep posterior muscles, which includes flexor digitorum longus, then flexor hallucis longus, and then tibialis posterior muscle. Next, anteriorly, we have tibialis anterior muscle, which helps in ankle dorsiflexion. Now, in runners, what happens? They have a tight triceps surae, or the tight gastrocnemius of the soleus muscle. So this muscle inflexibility will lead to there'll be muscle imbalance. So this muscle imbalance ultimately leads to causes undue stress on the tibia, which ultimately leads to shin splints. Yeah. So now, what are the factors which causes shin splints? First thing is repetitive running on hard surfaces. So when you run on an rocky ground that you can see here, or running on an uneven surface or a hard surface, again, these are high impact activities. So again, the force is added, that there will be added strain onto your anterior leg muscles. So this puts extra strain on your tibia, leading to shin splints. The second one is downhill fell running. This is nothing but when you run down the steep hill. So runners, what do? They try to stop heavily on their heels. So this stopping heavily on the heels puts extra strain on the anterior leg muscle, that is the tibialis anterior muscle. So this again, since tibia is not covered by any bulky muscle, so this muscle cannot take up that strain, and this force is transmitted to the tibia, causing pain in your tibia. Next, third one is bad running shoes. Now, suppose when you run in shoes like which you use for casual purpose, these shoes will not have a proper shock absorbing property in it, and will not have any proper arch to support your foot arch. So when you run in these shoes, again puts extra strain on the bone, leading to shin splints. Now, fourth one is foot arch abnormalities, which includes pes planus, that's the flat foot, and then the pes cavus, which includes the high arched foot, the arch above the normal arch. So when people with such foot arch abnormalities, when they insist on running, um, so there is something called impact forces. So that is the force which is exerted, which is transmitted up the leg when the foot hits the ground. So since there is abnormality in their arches, uh, the force is not equally or well distributed. So this again transmits to the tibia bone, and ultimately leads to shin splints. Now the fifth one in runners, like in athletes who are taking training, when you suddenly increase their intensity or duration or frequency. So when there's sudden increase in these components, any one of these components or all the components, uh, there will be extra strain on the tibia or extra stress on the tibia, leads to shin splints. Now, it's not only found in athletes or sports person, it's also found in dancers, especially the ballet dancers. So in ballet dancers, what happens, as you all know, they keep their foot pointed. So there is recurrent movements like ankle plantar flexion and ankle dorsiflexion. So these are the movements which ballet dancers do. So because of this, there is overuse injuries of the anterior leg muscles and the posterior leg muscles. Again, which ultimately, when these muscles are not strong in them, puts the force gets transmitted to the tibia, and it leads to shin splints. These colorful tapes that you all can see is the kinesio taping, which they put, it gives them relaxation to their muscles and help in pain relief. Then this, what you can see is nothing but these are the Irish dancers. So they are more prone to get shin splints. Why? Because they are dancing. Irish dancing includes more of tapping, tapping of the foot. More movements are in their lower limbs. So, and one more thing, they dance on the hard floors, very hard floors. So these factors plus look at the shoes or the footwear. It's completely flat. There is no arch support. There's no cushioning. So all these factors puts strain on their tibia. So they are more prone to get shin splints. Yeah. So now I'm done with the factors. Now let's go to the features. What features you can see in shin splints? So when you palpate on the area of pain, especially on the posterior medial part of tibia, there will be tenderness present. That's the first feature. Secondly, there will be gradual onset of diffuse or localized exercise induced pain at the posterior medial aspect of mid and distal tibia. So, important thing is there's gradual onset of diffuse pain. Third one, this is very important feature. Now, when a client or when a person comes to you, he comes with these complaints. That is, he says in the beginning of the workout. So when I start exercising, I don't I get pain, but when I start my exercise at the 10th minute or 15th minute, the pain disappears. But again, when I stop the exercise, when I come down to the cool down period, again the pain appears. So this is a classic feature of shin splints. But at worst conditions, what happens? The pain will remain even during the exercise time, and this could be present for hours or days after the cessation of inducing activity. Now, the fourth point, there could be mild edema because of inflammation of the periosteum of the tibia. Then the fifth one, very important, there is no neurological symptoms in shin splints. Um, that is, there won't be any tingling sensation, no pricking sensation present. It's just a strain or stress on the tibia. Yeah. Now let us go to the investigations. First one, X-ray. So shin splints, X-ray will be normal. We need to take X-ray to rule out other diagnoses. For example, if a person has got tibial stress fractures, they will have the same complaints. They will have pain in the tibia. There can be swelling. So in order to rule out different diagnoses, we do X-ray. In stress fractures, X-ray will be abnormal, whereas in shin splints, it will be normal. Second one, MRI. There will be subcortical edema along the posterior medial tibia because of the inflammation. Then third one, bone scan results will be abnormal. So this image, which you can see, this is the anterior view and this is the posterior view. Look at the left low leg tibia. There is a black color. So this dark color shows there is some strain in the tibia. Bone scan is nothing but we inject radio tracer fluid into your bloodstream, and this radio substance will not stain your tissues. It will be taken up by the bones. Okay, so and that part of the bone where there is abnormal bone metabolism happening, so that part of the bone takes up this radio fluid, and it will be evident in your bone scan. Okay, so let's go to the management of shin splints. Around 80 to 90% of shin splints are the management is conservative management. Only in worse conditions we go for surgery. So any pain, the medical management will be non-steroidal anti-inflammatory drugs given, and that's acetaminophen, that's paracetamol for the painkiller. Then surgical procedure, what is done is fasciotomy. Fasciotomy is nothing but releasing of the fascia. Here, they will release the tibial fascia, which overlies the flexor muscles from the tibial border. So that's fasciotomy. So only in worst conditions we go for fasciotomy, or else the entire management is conservative management. So first we do ice massage. So it's a natural tendency to put ice whenever you fall or whenever there is pain. So yes, we can use ice ice massage on the pain area for 7 to 10 minutes continuously, and we can do this for 3 to 4 times per day. So this ice will relieve your pain and reduce swelling if swelling is present. Yeah. Now this is the second. What we do is stretching. Stretching of both the anterior muscles and the posterior muscles. Now this first image, which you can see, it's the stretching of the gastrocnemius and the soleus muscle. This is superficial posterior muscles. The person stands with the affected leg behind and unaffected forward, and pushes against the hand, pushing against the wall, and the person should push the heel towards the ground, against the ground. So what we need to keep in mind is the reference point. That is, the knee should be in complete extension. So then only the uh, gastrocnemius and the soleus muscle gets stretched. This is the first one. Second method is this. The patient sits with, again here, knee should be extended. It shouldn't be flexed. The person can take a belt or a belt or some band and take it around the foot and then pull towards himself. So pull it towards himself. So there will be stretch in the posterior muscle. This is the third image. See, this is similar to the other one. Only difference is here knee is slightly flexed. So this will stretch your posterior tibialis muscle. Next, this last image is stretching of the tibialis anterior muscle. That is the anterior muscle of the tibia. The person should sit with the ankle plantar flexed, and the patient should sit on their heels. So this will automatically stretch the anterior tibialis muscle. Next, let's go to the strengthening. Again, we need to strengthen both the anterior muscles and the posterior muscles. So this is tapping. The patients should sit on a chair with the heel in contact with the ground, and then tap against take your foot again away from the ground. So this will strengthen your anterior tibialis muscle. Progression from sitting, we can go for standing. Do the same thing. You can do bilaterally or unilaterally. Then we can also use resistance band for strengthening. Take a resistance band, tie it wrap it around your foot, and one end attached to the rigid object, and the other one over the dorsum of the foot. So then you need to dorsiflex your ankle against this resistance, which is applied by this resistance band. So this will strengthen your anterior tibialis muscle. Next, how to strengthen posterior muscles. Heel raises, bilateral. These are heel raise, unilateral. Then this also can be done alternative toe raise and the heel raise. Then here also we can use the resistance band. Take the resistance band, wrap it around your foot, and you need to pull it towards yourself. The direction is this way. And simultaneously, you need to flex your ankle against this resistance band. So this will strengthen your posterior leg muscles. Yeah. Now, this is a taping method, which is done mostly for the overpronation. That is when you run, if your foot is turning inwards, okay, or people with flat feet. Okay, so we do taping. So the materials required for taping, you need adhesive sprays. Then you require tapes, which can be 2.4 to 3.8 centimeters according to the foot size. Then the patient position will be lying down with their foot outside the couch at the end of the couch. Now, before starting, we need to make sure that the person or the client is not allergic to the adhesive sprays and also not allergic to the tape as well. So first step, we need to spray on the area where it has to be taped. Then take the tape, start from the uh, lateral border. Okay, start from the fifth metatarsal head. Take it all the way around the lateral side. Take it around your heel and then come to the medial side. So come to the medial side. Then second step will be you need to depress the first metatarsal with your index finger and then support all the other metatarsals with the other fingers. So take this tape all the way through the medial border and then after depressing the first metatarsal, then apply the tape on the first metatarsal head. Okay, so look at this image. The first metatarsal is depressed here and the tape is put. So we can put 2 or 3 strips on that. Now, this is the fourth step. Take 2 or 3 strips again. Take it from the lateral all the way through the arch and then bring into the medial side. That's the fourth step. Now, the fifth step, you need to make the client weight bear or stand. And then these are the bridging tapes which is applied. Bridging tapes from the medial towards the lateral side. So this taping method is basically done to limit abnormal pronation and help runners with a flat feet run comfortably. Next, okay, so before going to this, there are other various treatments for shin splints. There is ultrasound, you can give iontophoresis, phonophoresis, then pectoral periosteal pecking. So there are various other techniques which have beneficial effects, but it lacks evidence. So yeah, now if symptoms doesn't decrease in 7 to 10 days, so you need to send the athlete to a physician for further evaluation and to rule out the possibility of a stress fracture or anterior compartment syndrome. I already spoke about this stress fracture in the investigation part. So there are differential diagnoses. So you need to rule out all of it. Yeah. So I'm done with the treatment part. Now let's go to the prevention, which is very important. So first, the shoes that you put. So these shoes, the sports shoes, okay, so they have proper cushioning, proper shock absorbing capacity in them, and proper arches. So you need to wear those shoes and go for running or jogging, whatever it is. Next, second one, the cushions and the arches of the shoes, so they break down within a span of time. So you need to replace it accordingly. Then third one, it's good to avoid running on hard surfaces, especially when you've got pain on your tibia. Avoid running on hard surfaces. Now fourth one, weight loss in obese or overweight runners. Weight loss is recommended. Then fifth one, graded running programs. This I already spoke in the previous slide, that whenever you're training an athlete, don't suddenly increase their distance or frequency or intensity. Go in a graded manner, graded running programs. Yeah. Now the sixth one, in overpronators. So in overpronators, I already spoke about taping. So you can do that. And there is one more thing, that is motion control training shoes. So these shoes are made especially and more specifically for overpronators. So you get these shoes in the sports shops. You get these. So these shoes are mainly made for overpronators. And there are medially posted orthotics can be inserted within the arch. And there are shoe inserts that you get, which can be custom made according to your arch, or it can be bought over the counter. Yeah. Now, to prevent re-injury upon return to play, make sure the athlete progresses slowly in returning to normal activities. Yeah, so this part is very important. Now, suppose an athlete who has been like training from many years and suddenly he gets shin splints, and because of this, he's not able to run every day. So, in order to maintain his physical fitness or general fitness, the best exercise you can do is cycling and swimming. So, since these two exercises are non-weight bearing, they are low impact activities. So, these can act as good alternatives for running. Yeah, so these are the references. I referred Sports Medicine Essential by Jim Clover, second edition. Then the Sports Injuries Handbook, Diagnosis and Management by Christopher Rolfe. Routledge Handbook of Sports Therapy, Assessment and Rehabilitation. Taping Techniques by Rose McDonald. And Therapeutic Exercise, fifth edition by Carolyn Kistner. So thank you. So I would like to thank my college, St. John's College Physiotherapy Department, for their support and guidance. Then I would especially like to thank the ExRx team for giving me this opportunity and the platform to learn something new and share it with everyone. Thank you, sir. Thank you, ma'am. Thank you.
Thank you, Michelle. A wonderful presentation. And we would like to thank Dr. Annie Thomas and all other professors from St. John's Medical College, College of Physiotherapy, for encouraging the students to present their topic in our ExRx India's for the students, by the students web series. And I thank all the participants and our ExRx India team members, Dr. Rupesh and Professor Tuna. Bye-bye.
Yeah, thank you.
Welcome. Bye-bye.
Bye-bye.